All right, and like I said, this is a PowerPoint that I kind of came up with. It's going to review some of the stuff that we should have that I feel like was a little more important out of those slides that isn't going to take 240 slides. I mean, some of that stuff was important. Yes, I agree. But some of it was um, just extra fluff added, in my opinion. And I can only imagine it confused some of you probably at the same time. So just again, some basic review with pharmacology. So a drug is any foreign substance placed in the body. Okay, and this can be whether it be a legal prescription medication or to be an illegal medication, it can still be classified as a drug. So any substance placed in the body that's foreign, that the body isn't essentially used to having as a natural binding agent or catecholamine, whatever it might be. Medication-wise, and medication is any drugs or chemical used to diagnose, treat, or prevent any sort of disease. So let's take Humalog, for example. Humalog is prescribed to diabetics to help maintain blood sugar issues. So even though it's insulin, which is a natural hormone inside of our body, it's been altered somewhat to where it can be, injected through a sub-Q or IM route to where this patient can have that medication metabolized, and it's used to treat the diabetes in that sense. So that would be an example of your medication. And then pharmacology, obviously, what we're doing now, study of medications and the act they have on the body, the different organ systems. Maybe it's a drug that acts on the central nervous system. Maybe it's a drug that acts on the peripheral nervous system. I know last week we kind of talked about your sympathetic and parasympathetic systems, which we'll get into that a little bit as well. But pharmacology, again, how do these medications act on the body and what response can we see from a medication? So when we talk about a drug profile, and a lot of this is stuff that you guys might be putting on your drug cards, and I'll be honest with you because I've had a couple people ask me is, I don't go through each individual medication that I have listed for you guys to go through in your drug cards. That's for you guys to study on your own, to, for self-review or self-study, or even with somebody in the class for you to go through. That's how you're going to learn medications. I can sit here and put PowerPoints up all night. You're not going to learn them that way. It's getting out there. It's holding a medication. It's looking at it, knowing what color it is, knowing how much is in a vial, knowing what we use it for. That's how you're going to learn, not going through PowerPoint. So again, those drug cards are for you to study throughout this whole paramedic program as to what the medications do and how much we should be giving dosage-wise for possibly adult and pediatric patients. But looking at our drug profile here, this is kind of what we would see on our drug cards. So I used atropine as an example. Atropine sulfate, classified as an anticholinergic. So remember, we have, like norepi, and then we have any of the like almost paralytic for the parasympathetic system. So it's going to stop the vagus nerve. And what a vagus nerve is like when a patient vagals down, if anybody's ever had that on the toilet, it's essentially a brake for our heart, because it feels like our heart is going too fast, so it tries to slow it down. So atropine works by preventing the heart from breaking. That's why we get an increased heart rate. Indications, we use this for bradycardia, stemming from possibly a cardiac issue. Pharmacokinetics, I couldn't really find anything on it. So side effects, adverse reactions, anxiety, tachycardia, because you got to think, obviously, you're speeding up their heart rate. They're going to feel anxious. They're going to feel like their heart's beating out of their chest. That's normal. Our different routes of administration for this medication. So we can give it IV or IM. And again, it's what they use to dilate your eyes. So it can be given in that sense as well. Contraindications for atropine, any allergies to it. How supplied, 1 milligram and 1 ml is pretty standard, whether it be in a Bristow jet or whether it be in a vial that you have to draw up or even an ampule. And then special considerations, again, I wouldn't put the pregnancy class A in there, meaning that it can have an effect on our patients that are pregnant. Our schedule classifications, again, just a quick review. Schedule 1, high abuse potential, such as heroin and LSD. These are medications that aren't used in the medical field at all. Cocaine would be another example of a schedule, but a little bit lower because actually there are cocaine derivatives that are used for medication. So mainly your Schedule 1s are going to be your heroin and LSDs. Schedule 2 is where your cocaine is going to fall in. Opiums, so fentanyl is a good example of that, is an opioid. oxycodone, so you get maybe hydrocodone, codeine, morphine. So any of the medications that are highly addictive, but used to treat something generally for pain management. Schedule 3, moderate to low dependence, again, would be codeine or acetaminophen. So those are basically over-the-counter drugs that people can take and become, addicted to if they take them over a period of time. Absolutely. Ketamine is also going to fall into Schedule 3. Schedule 4, low abuse. This is going to be our benzos. A lot of times used for seizures or anxiety. And the bad thing about it is you're actually seeing an uptick in patients that maybe are prescribed Ativan that become pretty dependent on it. But again, it's because they take it over a longer period of time. And the Schedule 5 is going to be the lowest abuse potential. And that's going to be such common medications as cough or diarrhea medication. Bioavailability. So after a drug reaches its target and it does its job, so we'll use atropine for an example. After atropine works, speeds up our heart, there is still a amount of that drug that is left in our system. And that is measured when we talk about bioavailability. We're talking about that amount of medication that is left. Distribution obviously should be pretty simple. Once it enters, how is it spread throughout the body? Is it through the bloodstream? Is it injected into tissue? Is it injected into mucosal membranes? How is it administered, and then how does it travel? And then biotransformation. How does this drug metabolize? Again, a lot of medications metabolize in the liver. So that would be, the biotransformation of, let's say, ibuprofen would be that it is metabolized in the liver. When we talk about drug actions, we're looking at some receptor sites here on the left side. Where's my laser pointer? So if you look at this top one, we have a receptor site and we have a puzzle piece for a neurotransmitter that fits in it perfectly. That means that is a natural reaction, such as like adrenaline. Our body is used to it. It has a receptor site for adrenaline. Go down one to the purple one. That is agonist is like a medication we can give that can mimic that. So again, it fits in there like a puzzle piece pretty neatly because it's been synthesized to do so. Then you go to the bottom, that's a drug that has no pharmacological response. So a good example of this would be like Narcan. If Narcan is administered to somebody that hasn't overdosed on any sort of opioid, it won't do anything to them because it doesn't have those receptor sites for that opioids are bound to. So that'd be a pretty good example of that. Onset of action, the time from when we administer the medication until we see the desired effect. So fentanyl, I give fentanyl, let's just say I give 50 or 100 micrograms for pain management, generally say 3 to 5 minutes before you can see a response from patients. So that would be the onset time of fentanyl. Your drug response relationship. So different amounts of drug to different clinical responses. A good example of that is ketamine. Ketamine comes in two different, we use it for two different things. We use it for pain management and we use it for possibly, excited delirium. It's got two different dosages for that. For your pain management, you're looking a little bit lower dose, 0.1 to 0.3 milligrams per kilogram, I believe. And then for your sedation or excited delirium, you're looking a little bit higher, about 1 to 2 milligrams per kilogram. So same medication, it's just a different amount, has a different clinical response and a different indication for why we're using it. The duration of action, how long does this medication last in our system? Again, fentanyl is another good example. We can expect to see it wear off anywhere from 10 to 15 to 20 minutes after it's administered because it's very quick acting. It takes the edge off the pain, but it doesn't last a very long time unless we're giving a larger dose of it. And then your half-life. Time it takes for the body to clear one half of the drug. This is the thing that people, again, get kind of confused on, is our different systems of the body. So our sympathetic system, our fight or flight, what happens there is our pupils dilate out, respirations increase, heart rate increases, blood vessels constrict, because as our blood vessels constrict, our heart rate ramps up. It's all kind of, yin and yang. And then we have our sympathetic system. So when we start to calm down a little bit, we get home from work, or um, we've had a long day out running errands or something like that. We get home and sit on the couch, and our parasympathetic system kicks in. Our pupils constrict because they're not worried about seeing as much around them. Our respirations decrease. We don't need to breathe as fast. Our heart rate slows down a little bit, and our blood vessels dilate. That's why we give fentanyl to people that are in pain. And you can usually tell somebody's really in pain because their heart rate will be above 100. Well, if we give them pain meds, we'll usually see their heart rate decrease. And it's because their parasympathetic system's kicking in and starting to calm them down a little bit. Just a simple review of our nervous system. So again, we have our central nervous system, which consists of our brain and spinal cord, and then our peripheral nervous system, which is all other receptor sites that are outside of our central nervous system. So this would be like any of our nerve endings or anything that are within our limbs, with anywhere else in our body besides our brain and spinal cord. Then we have our autonomic and somatic nervous systems. Autonomic obviously is going to be automatic functions such as breathing, such as blinking our eyes when we're not really paying attention. And then our somatic is the ones we control, such as, hey, your mind says, I want to grab that glass of water. It sends a signal, your arm reaches out, sends a signal back to the brain saying, okay, I've done what you asked. And that's kind of how we function. And then off of our autonomic, we have our sympathetic fight or flight and our parasympathetic feed or breathe. I heard a couple people say that this kind of stuck with them a little bit, and I'm glad. Which is the common receptor sites that we're going to deal with when we're talking about medications, which is your alpha, beta 1, and beta 2. Alpha, any medication that has alpha properties creates vasoconstriction, such as epinephrine. Beta 1, increased heart rate, so one heart. Beta 2, bronchodilation, so two lungs. Epinephrine is a great drug, as an example, because it has alpha, beta 1, and beta 2 properties. It's used to create vasoconstriction because it's adrenaline, and it ramps up our sympathetic system, increases our heart rate again because it's adrenaline, and then creates bronchodilation. That's why for severe asthmatics or severe COPD patients, we can give them an IM dose of epinephrine to hopefully open them up a little bit, especially, allergic reactions is a pretty good example. Some of the common pain medications, and again, if your service carries something different, or maybe the dosage that you guys carry is different, please pipe up when I'm talking about them. So any time you hear the word analgesic, it's a medication that relieves the sensation of pain, such as fentanyl or morphine. And then analgesia being the absence of sensation or pain. So when we've reached a state of analgesia, they're not in pain anymore. This would be a patient that you give ketamine to. They suspect that have a broken hip or a broken knee, and you get into the hospital and they just want to, hey, I feel okay. I can stand up and walk out of the ambulance. That's because they don't have that pain receptor site going off, blaring at them, saying, hey, I'm in pain. Anesthesia, obviously the absence of all sensation. That's when we're talking about possibly paralyzing our patients for the need of RSI. And then opioid antagonists reverse the side effects of opiates, but be cautious if you're going to give Narcan, for the simple fact that once you give it, you can't give pain medication behind it. So if you have somebody that maybe overdosed on pain medication accidentally, especially an elderly person, maybe you give them Narcan, they come around and they're just in this massive amount of pain because it's chronic for them. You can't give them anything on top of that because it's not gonna have an effect on them. So some of our common medications that we'll carry pre-hospital. Fentanyl citrate, another word for it is sublimase, is a narcotic opioid, creates analgesia, so that sense of without pain, by binding to analgesic receptor sites. Contraindications to fentanyl, allergies or medication sensitivity. I'll also throw in there low blood pressure, and if the patient is unresponsive, we're obviously not going to give them fentanyl. Dose can vary. You'll see two different doses, common dosages. I've seen lower than this. 50 to 100 mics or 1 mic per kilo are pretty common dosages. Some services will do 25 to 50, but again, it's just service dependent. Can be given IV, IO, IM, sub-Q, or intranasal. Be sure that if you're going to give somebody fentanyl, you should probably put them on cardiac monitor. You should probably have them at least on a 4-lead. for the simple fact that we want to monitor their heart rhythm and what their heart's doing when we're giving them fentanyl. And then some of your common side effects, which I misspelled the first one. Nausea, cramping, vomiting, and potential respiratory depression, potential hypotension, drop in blood pressure. So there's a couple different side effects, and it really depends on the person as well.
Rudy, when it comes to dosages, what are we going to be tested on?
That's a good question. I would say refer to your book on what that dosage says. Because I want to say it's 50 to 100, to be honest. But I threw the 1 mic per kilo in there because that's a lot of protocols are written that way now. But yeah, I would in your book, look up fentanyl and see what dosage it gives you. It might actually give you both of them too, if I remember back to the last PowerPoint. But as far as testing or anything like that, at least for my tests, I won't throw, hey, is it 1 mic per kilo or 50 micrograms? Because you guys aren't operating off protocols as a paramedic student. The NREMT won't ask you a question like that either. It'd be like 1 mic per kilo or 200 micrograms. Which one's the right dose? They don't put the questions that close together or answers that close together. All right, another one that we're pretty common with is morphine. It's kind of going by the wayside a little bit. We still use it for some of our cardiac patients potentially. Narcotic opioid creates that absence of pain by binding to analgesic receptor sites. Contraindications, again, allergies, hypotension. That's why I always ask my patients, hey, are you allergic to anything before I give them medication? Because I need to know that. And you'll find that a lot of people are actually allergic to morphine or some sort of morphine derivative. But I also ask, well, what does it do to you? What kind of allergic reaction do you have to it? Is it okay, I just feel funny, or my throat itches, or do you go into a full-on anaphylactic reaction? Because I can give somebody Benadryl if it just makes them feel like their throat itches, especially if they're in pain. Again, since it is a narcotic, we need to consider cardiac monitoring. Side effects, again, can be the same as fentanyl: your nausea, cramping, vomiting, potential apnea, potential respiratory depression, hypotension. Those are all going to be pretty common with your narcotics, your pain medications. Ketamine, does anybody service not carry ketamine by chance? Or do you not know, maybe? All right, so it is a dissociative. Again, how it works is by essentially separating your brain from the rest of your body. It takes your central nervous system and kind of puts it in its own world so that you can't feel pain, so that you don't have those receptor sites that can feel pain. They'll use it a lot of times, excuse me, as an anesthetic during surgery, maybe for induction. Contraindications, allergies, and hypertension. Ketamine is a good drug because if a patient is hypotensive, you generally won't lower their blood pressure. You will actually see a rise in blood pressure by giving ketamine, and you generally won't see respiratory depression as a side effect of it. Dose, again, with ketamine varies. This is one I found in the book. It can vary based on the service. This is a drug you will probably, when you're tested on drugs, they will not be drugs like ketamine. They will not be drugs that aren't available everywhere nationwide. All the drugs you'll be tested on are drugs that every service carries. You got to think, because the NREMT, not every state carries the same stuff. Not every states allow a ketamine to be given by providers. So this is a drug you won't be tested on. Common routes of administration: intravenous and intramuscular. Cardiac monitoring, obviously, since it is it's still a class 3, but it is still a narcotic. And then side effects: if pushing too fast, you will see hallucinations with patients. And when I say they'll hallucinate, I mean they'll make stuff up that you've never heard of before, and it's kind of terrifying, to be honest. All right, common benzos. So this is medications we use to treat seizures. This is medications we'll see people prescribed for anxiety. First one being diazepam, the other name Valium. Again, classification is benzodiazepine. All of them are going to react the same when they bind to receptor sites, which is our GABA receptors, which will create sedation. Some of our indications anxiety, seizures, sedation, muscle relaxants. Valium is really good for seizures. The problem with it is it's a little bit thicker medication, so you generally can't give it intranasal. So that's why you'll see down in the routes that I don't have down there. 2 to 10 milligrams is a pretty broad dose as well. I'd say if you're given 10 milligrams of a benzodiazepine, you're probably looking to sedate somebody. A more common dose would be like 2 to 5. And then your reversal agent, again, I don't know of any service that carries Romazicon anymore. It was given a 3-part dose. I think it was 0.2, 0.3, 0.5, if I remember right. And that's how you reversed a benzo. But the problem was they were finding out that had patients that overdosed on this. They were giving them the reversal agent. Well, the person accidentally overdosed because they were having a seizure. They gave the reversal agent, the person started seizing again, and they couldn't give a benzo because it would have no reaction on the patient. Another common one, Versed. Again, same classification, binds to the same receptor sites, same indications. I personally like Versed. It's one of my favorite drugs to use for seizures and pain management. Dose 1 to 5 milligrams. Generally comes in a 10 milligram and 10 ml vial, so 1 milligram per ml. So it's pretty easy to draw up. Going to be the exact same since it's the same classification. But again, this is more of a common medication you'll see in the field. Same with lorazepam or Ativan, except your dose is going to be a little bit different. I'd even venture to say your dose would be 1 to 5 on this as well. But remember, anything that ends in AM, midazolam, diazepam, lorazepam, those are benzodiazepines. When you start to look at like the suffix of the word, you can really start to determine what medication it is. And when we get into cardiac medications, some of the other medications, not like the ones I want to give you tonight, you'll see that the suffix on them is the same. For like our blockers, maybe a beta blocker, maybe a sodium channel blocker, maybe a calcium channel blocker. They're all pretty much the same, so you can tell usually pretty quickly. Some of the common paralytics we'll carry. First one being succinylcholine. This was the only one I was taught when I went through paramedic school. Nobody thought about giving vecuronium. Nobody thought about giving rocuronium. So it's changed a little bit since I went through. This is a depolarizing neuromuscular blocker. When I say depolarizing, what you're going to see with patients is, again, they're going to vesiculate a little bit. You might see their eyelids twitch when you give this. And it causes that depolarization. It causes their muscles to expend all the energy that it has built up, and then it prevents them from essentially resting and getting that burst of energy again. So it stops their muscles from resetting. Indications for SUX is RSI. Some of our contraindications, this is why SUX isn't used a whole lot anymore. It's because it does have a handful of contraindications as hyperkalemia, so an increased potassium, neuromuscular disease such as muscular dystrophy, crush injuries. The reason for that is because patients with crush injuries, when we start to maybe release the crushing, we'll see a rush of potassium. Burns, same concept. And then any sort of intracranial pressure that is increased over baseline, because SUX itself can also cause increased intracranial pressure. General dose for it, 1 to 2 milligrams per kilogram, IV or IO. Obviously, it is going to cause respiratory depression and apnea. That's our goal with it. I'll tell you, if you're going to give this medication, do not give it before you give any sort of pain management or anything like that, because once you give a paralytic and you don't give them any pain management, they can still feel everything. It's just they can't react to it. I've literally seen patients before that somebody gave them SUX and then went to intubate them and forgot to give another medication, and the person was literally just like water was just rolling off their eyes because they couldn't cry because they were paralyzed. It's an uneasy feeling. One of the least common ones I'd say anymore, I don't see a ton of places carry this. I do know a handful that do, is vecuronium. It is a non-depolarizing, so it doesn't get that vesiculation of the muscles. You don't see the eyelids twitching or anything like that. This blocks the neuromuscular action, so you will not see, the patient won't be able to move at all in that sense. Again, used for RSI. Dosage is a little different. This is why I think a lot of people don't carry it, is because how you have to draw it up. 0.1 to 0.15 mg per kg. Contraindications are fairly low on this and rocuronium. They're, that's really only if they're allergic to it or sensitive. I don't think I've ever had a patient tell me they were allergic to a paralytic, probably because they don't know they are if they are. And then what you'll see more common, rocuronium. Rocuronium has a onset time of about 30 seconds, and it can last about a duration of upwards of 45 minutes, as opposed to Sucks, which has a duration of about 5 minutes. So that's why Sucks is a little bit safer in that sense, is because in 5 minutes that paralyzing agent's wearing off. With Rock, you've got 45 minutes before it starts to wear off. So you'll see this carried by a lot of more rural services, or that maybe, you know, a critical care service, or they're doing over the road transfers. Dose is easy, 1 mg per kg. Otherwise, everything is going to be the same as it would for vecuronium. All right, some of our common cardiac medications.
I have a question quick about the last section.
My bad. Yep. Okay.
Would etomidate be considered a disassociative?
It is like a hypnotic.
Okay.
So yeah, and that's why for RSI we give, you know, 0.3 milligrams per kilogram of etomidate prior to giving some sort of paralytic, is just to kind of put them in a state of not knowing what's going on.
Okay.
I also have a question about gabapentin.
Mm-hmm.
I don't know any service that actually gives it, but I have seen overdoses of gabapentin, and all we can do is monitor. Is there a reversal agent for it or no?
So gabapentin is actually it was first used as like an anticonvulsant, kind of like a benzo was. As far as the reversal agent, I want to say, I can't exactly remember. I want to say it was romazicon, just because it's not an opioid derivative. So Narcan doesn't essentially work on gabapentin. I mean, you can try it. I guess I've never tried giving Narcan to somebody with gabapentin. But a lot of times gabapentin is prescribed, especially in our elderly populations. You'll see that prescribed more often than not for pain medication for them, because it doesn't have that narcotic effect. And a lot of times, believe it or not, what it's given for is like diabetic neuropathy. I'd say probably, you know, 40 to 50% of what it's given for is diabetic neuropathy, just to deal with that pain, or like nerve ending pain. But yeah, it started out as a anti-seizure medication.
Okay, yeah, I was just curious. Like I said, I've never given it to anybody, but I have seen overdoses of it, and it's just depression everywhere.
Yep. And that's, you know, and sometimes instead of a reversal agent, we might just have to treat the patient's symptoms, especially if we don't know of any reversal agent or we don't carry it. You know, they overdose on that. They've got low blood pressure. They're not breathing. That's the event where you're, okay, let's start an IV. Let's start getting them some fluid. Maybe we have to look at maintaining this person's airway for them just because of the state that they're in. But yeah, and that's a good question. That's a medication that a lot of people don't consider as gabapentin. And again, it's something that we do commonly see, especially with our geriatric population.
And what about interactions with other drugs? Like, what if they became aggressive or anything? Could we give them something to calm them down, like another benzo or anything?
They're taking gabapentin? Is that what you're saying?
Yeah.
Yeah, absolutely.
Say one instance, I remember guy was psychological depression. He threatened to hurt himself. We had police on scene. He was passively combative with the cops, very resistant, but he ended up wanting us to take him, and the cops wanted us to take him. And he tried, I don't want to say he was fighting, but he was very resistant.
Mm-hmm.
And I didn't know if like a benzo would have any effect with the gabapentin or anything.
Yeah, absolutely. It actually might enhance the effects of gabapentin. Yeah, you can actually absolutely give a benzo on top of that if you need be. I mean, it'd be no different than somebody taking Ativan at home and having an anxiety attack, and I give them Versed in the ambulance. It'd be the same concept. But yeah, absolutely you can. Where gabapentin becomes real scary, and I know this just from patients that I've had, especially is if they're drinking, they take gabapentin, or they're taking some sort of opioid with gabapentin. That's when it really starts to become an issue, because the way that binds with the medication almost like triples the dose and makes it that much more potent for them.
in a situation like that, would Narcan be able to cancel out the opioid, but not the gabapentin? Or like, what kind of effect would we see with that?
Well, and that's if it's taken with an opioid, yeah, you might see. You can use Narcan if you're sure that's what's going on, but I don't think you're going to see any positive effects from it by giving it, because it's transferring from one drug and now is metabolized and essentially has that, oh god, what's the word I'm looking for? Polypharmacy. So where you mix many medications together, it has a different effect on the body. So it's not just the opioid that's creating that. It's the all three substances combined that could potentially be given the issue. But I mean, I can't say I've never done that in that instance, to be honest. I'll have to try it on my next gabapentin patient. Just give them intranasal Narcan, see what happens. But I do know gabapentin generally has a really short half-life. And I don't mean like super short, but I know like my grandfather takes gabapentin, and I want to say he takes it 4 or 5 times a day. So what that tells me is that it doesn't last very long, because they wouldn't want you to just put dose on top of dose on top of dose. So you might get 3 to 4 hours out of it, which that tells you when you arrive there and they say they overdose on it, it's within that time frame. And honestly, that's an example where if you're not sure if there isn't a reversal agent for gabapentin, which again, I don't know off the top of my head if there is. I guess I can look it up at the break. Call for medical control. I mean, again, that's a fairly common medication that they're used to. And it might be something as simple as giving fluids to try and, thin them out a little bit to try and flush it out of their system.
Yeah, that's all. I remember having encounters with it in the wild, and I'm just curious about it.
Here we go. There is no antidote for gabapentin. Nope, there is no reversal agent. So yeah, it's essentially let it run out of their system. Good question, though. All right, let's take like a 6-minute break, and then we're going to come back and talk about our. Actually, we'll do 9 minutes, so that's 6:45. We'll come back and talk about some cardiac medication. So about 9-10 minutes, and we'll come back and finish this. All right, let's hop back in and finish up some cardiac meds, and then I don't believe there's many slides left of this, and then we're going to talk about some med math, and then Thursday night for skills. And when we come back to Mesa City, we're going to spend a lot of time on med math. So for those of you that feel like maybe you're a little deficient or need a little more work on it, trust me, we got you. All right, first medication when we talk to cardiac meds. Adenosine, also goes by the name Adenocard. It is an antiarrhythmic, generally used for the treatment of SVT or wide complex tachycardia of unknown origin. Contraindications, any heart blocks. We don't want to give adenosine for any sort of heart block because for one, it might not work. And for two, it could actually cause the patient to tank. First dose of adenosine is 6 milligrams rapid IV push. And when I say rapid, I mean slam it, followed by a flush. Second dose is 12 milligrams. After that, if it doesn't work, then we look at calling the hospital and getting some sort of advice or medical direction on what we can do from here. IV, IO are 2 routes. Side effects, you will see a period of asystole. Once you slam this medication, the patient will flatline for about 3 to 5 seconds. That is normal before they pick back up, hopefully into a sinus rhythm and are no longer in a very fast rhythm. Again, this is used to treat a rhythm that is super fast. So I'm talking 150, 180 beats per minute, and essentially chemically stops their heart in hopes that their heart restarts itself on its own. Very common, every service carries it. Amiodarone, cortisone, another antiarrhythmic. We generally will see this used in cardiac arrest, so VFib and pulses VTAC, and also stable VTAC. If we have a patient that's stable in ventricular tachycardia, we can actually put them on an amiodarone drip. So contraindications, obviously, if they have a slow heart rate and they're not in VTAC, we do not want to give this. If they're hypotensive, we don't want to give it because it can further cause hypotension. Cardiac arrest dose. Our first dose in cardiac arrest is 300 milligrams. Our second dose is 150. After that, we're done giving amiodarone. If the patient has a pulse and they're in VTAC, which will make more sense when we get to cardiology, we administer 150 milligrams over 10 minutes. Now, you can sit there and slowly push it over 10 minutes if you want, but I'd recommend putting it into a bag of saline and dripping that in over 10 minutes. Side effects, again, bradycardia, asystole, dizziness, headache. The 2 patients that I've given amiodarone to try and convert, one worked, one did not. We just didn't see any effect at all of one, and then one did work. We had a pretty good outcome with that patient. So it really depends on what you're using it for. Atropine, I kind of went over a little bit. Anticholinergic, parasympathetic. So remember, lytic means the paralytic, it paralyzes that symptom or that system. So it paralyzes the parasympathetic system, doesn't allow the heart to slow down. Use it for bradycardia and organophosphate poisoning, such as herbicides. Contraindications, any allergies to it. Generally, nobody's going to have an allergy to atropine. Glaucoma. For bradycardia, our dose is 1 milligram. If we're looking at organophosphate poisoning, it's 2 to 5 milligrams. It's a lot higher dose. And again, it was something you can think of when we talk about organophosphate poisoning is sludgeum. So if you start to see the patient, crying and sweating and salivating, and there's a potential that they might have been sprayed with something, it's probably organophosphate. IV IO push, some of our side effects, dry mouth, chest pain, and cardiac instability. Now, if somebody has a slow heart rate, that doesn't mean go automatically pushing atropine. If somebody is having chest pain, or they're having a heart attack or STEMI, we don't want to give them atropine if they have a low heart rate, because by increasing the heart rate, I'm also increasing the oxygen demand to the heart. And if I do that, I could actually cause them to crash quicker. Also don't want to give it in traumas. I have a trauma that their blood pressure is lowering and their heart rate's lowering. I don't want to give them atropine. They've got blood loss somewhere. By giving atropine, you can actually cause them to bleed out faster. My first patient as a paramedic was a elderly female that had fallen in a care center. We got there and one of her pupils was blown, one was constricted. She was completely unresponsive. I'm losing it because I'm the only paramedic on scene. I'd been a paramedic maybe 3 minutes at that point. Called for additional assistance. I didn't get another paramedic to show up. We started transporting. Her heart rate was in the 30s. I started pushing atropine because that's what I do. Heart rate's low, I'm going to push atropine. Heart rate would come up for about 30 seconds and then drop right back down. Got to the hospital and she actually went into cardiac arrest on me, so I ended up coding her as we were wheeling her in. We get her into the trauma bay for them to tell me that she was diagnosed with a head bleed 2 weeks prior. So by pushing atropine, which I didn't know, but by pushing atropine, I actually sped up the bleed a little bit by increasing her heart rate, unfortunately. But she refused treatment for the head bleed and was actually at the care center for end of life care. I'm not a bad person. It makes a decent story to talk about atropine. Dopamine. You guys have probably heard a lot about dopamine. Sympathomimetic. So when I say mimetic, that means it mimics that system. So it mimics the sympathetic system. So you'll see an increase in heart rate. You'll see an increase in blood pressure. Used as a vasopressor. So vasopressors are used especially when we have somebody in shock from possibly cardiac origin. Produces positive inotropic and chronotropic effects. When we get into cardiac, we're going to talk about what inotropic and chronotropic mean. And you'll see an increase in blood pressure and preload. Now, the funny thing about dopamine is it's also used in dialysis. Low dose dopamine, that 2 to 5 micrograms per kilogram range, can actually cause renal perfusion. So by giving our patients a low dose of dopamine, we can actually see their blood pressure drop. So dose-wise, where we want to keep them in is that 10 to 20 microgram per kilogram per minute range. IVIO infusion. Generally, dopamine comes in a pre-mixed bag. If we have to mix it, no big deal. We're going to talk about that here in a little bit when we get to mid-math and how we would do that. Side effects, they're going to have a headache. You're increasing their heart rate. You're increasing blood flow. Hypotension, if you give low dose, sure. Hypertension, if you give too much. A lot of times you're giving dopamine until you get the desired effect, and then you want to slowly start slowing it down. You don't want to keep it going because it'll keep rising. It'll keep their blood pressure going up. Epinephrine, or adrenaline, as you might see it called, sympathomimetic, again, so it mimics the sympathetic system. Alpha and beta agonists, so alpha meaning constricting blood vessels, beta 1 for our heart rate increasing, beta 2 for our bronchodilation. Used in cardiac arrest, bradycardia for especially peds, allergic reactions such as anaphylaxis and asthma. Dose, allergic reactions would give 0.3 to 0.5 milligrams, 1 to 1,000 sub-Q IM. That's what is in an EpiPen. That's the exact dose that's in an EpiPen. If we have to give it IV push for allergic reaction, it's 0.5 to 1 of 1 to 10,000. So the dilution changes. Now, 1 to 10,000 is the same concentration we use in cardiac arrest. Cardiac arrest is 1 to 10,000, 1 milligram, which is one pre-filled syringe every 3 to 5 minutes. Routes, you'll notice something a little bit different about the routes here. We've got IO, we've got IV, we've got intramuscular, subcutaneous, but we have also ET. You can give epinephrine down an endotracheal tube. If you have no other means of access and you need to administer a patient a medication, you have a tube in, you can give that medication down the tube. The problem is the dose has to be about 10 times higher than what you normally would give. Otherwise, it won't have a reaction on the patient. One we're all fairly acquainted with is nitroglycerin, also known as nitrostat, vasodilator. So how it works by reducing chest pain is by opening blood vessels. We give nitro hoping that if there is some sort of blockage, when we dilate that vessel, that we'll see some blood flow past it and hopefully subside that chest pain. That's why you got to be kind of careful on what side of the heart they might be having a STEMI. And again, when we get into cardiology, that'll kind of make sense because I can actually drop their blood pressure too much, which can cause them to go into cardiac arrest. If they're already hypotensive, we know that as EMTs, we don't give nitroglycerin. I'd say to anybody under 100 systolic. Everybody will fight me and say, 90. 90 and 100 are close enough. 10 points to me, I'm not going to chance it. Dose 0.4 milligrams is in one spray, one tablet, and even nitro paste. Nitro paste is great, and I think I talked about this prior. If any services carry nitro paste, because you literally spread it on in a 1-inch area, it comes with its own little applicator pad. The good thing is if the patient starts going downhill, you can just wipe it off and the effects quit working immediately, as opposed to sublingual spray or tablet. All right. Any questions over that or any questions about meds? Again, this was a down and dirty to some of our medications, a very basic review on some of the stuff with pharmacology. I've got to figure out a way to get this pulled up. Can you guys still see my screen by chance?
Yes.
Yes.
Okay, perfect. All right, so let's talk about some math practice a little bit. So let's start with that first one, okay? And I want you guys to draw this out, and I'm going to post this on D2L so you can print it out and carry over your answers to it. But number one, you're responsible for providing the proper dose of etomidate to your partner so that he can initiate the RSI procedure for your patient. Patient weighs 175 pounds. You need to drop 0.3 milligrams per kilogram of etomidate into a syringe. First thing is, how many milligrams are required? How do we figure that out?
Need to calculate weight in kilograms, which is approximately 80.
Okay, so 80 kilos. Okay, so our dose. So how do we make pounds to kilograms again?
Divide by 2.2.
Divide by 2.2. Or me, I'm done with math. I cut in half and subtract 10%. Okay, so we divide by 2.2, or do the way that I mentioned, we get our pounds to kilograms. So if we're going to give 0.3 milligrams per kilogram, so 0.3 times 80, how much are we giving?
24 milligrams.
Okay, 24 milligrams. So there's answer number one. How many mLs will we have to draw up to achieve 24 milligrams? So this comes 2 milligrams per ml.
12.
Correct. There's 2 milligrams per ml. We need 24. 24 divided by 2 is 12. So 12 mLs. And how many syringes? Or how many vials? I'm sorry. How many vials do we need then?
2.
Yeah, 2 vials. Perfect. That kind of makes sense, or does anybody need any guidance on that? Nate, Mr. Robinson, I know you're on here. Making sense?
Yeah, I think so.
I'll call you out, buddy.
I appreciate it.
Rudy, can I be honest with you?
Yeah.
I appreciate that we're going over this, but I hate the fact that I can't see somebody writing it down while I'm doing it.
You know, and I'm trying to figure out a way, like literally that's what I'm messing with right now, that I can draw it while I'm doing it.
Yeah, that's kind of where I'm at. I kind of need to like have it on paper.
Let me see if there's a way I can pull up like a whiteboard here or something. Okay, then we're gonna have to make do with that. Okay, so we'll do 175 divide by 2.2 gives us our 80 kilos. We follow me there?
Confirmed.
Okay. So now with our 80 kilos, we need 0.3 times 80 because it's asking for 0.3 milligrams per kilogram. So 0.3 times 80 gives us our 24. I swear to God, my handwriting is usually not this bad. Okay, and we'll move on to the next one too, because that one I can draw a little bit easier. All right, so let's talk about this one. Remember that patient weighs 80 kilos. So patient is now asleep. We've sedated him. You give to your partner the syringe of succinylcholine, which is what kind of medication? So let's do this.
Depolarizing.
Get depolarizing paralytic, right? Okay. So based on the patient's weight, which I wrote there is 80 kilograms, the dose is 1.5 milligrams per kilogram. So 1.5 times 80 gives us what?
120.
120.
Okay. So that our dose would be 120 milligrams. How many mLs do we need to draw up then to get 120?
6.
Okay, so the reason we drop 6 is there is 20 milligrams for 1 ml. Remember, we don't put the 1, we just put ml. It's 20 milligrams per ml. How many do we need to get 120? Well, 20 times 6 is 120, so, or 120 divided by 20 equals 6. And you just carry over your mLs. That makes some sense, or is anybody good with that, or is it a little bit easier with me drawing it out like that?
Yeah, I think that's a lot better.
Perfect. Because some of these are going to get kind of hard, and honestly, we might skip them and just do those ones in person if they're hard. Same patient. So again, 80 kilos. I don't know what that was. Dose is 0.01, sorry, mg per kg. So 0.01 times 80 of vecuronium equals what?
0.8 milligrams.
Okay. Now this vial is supplied 10 milligrams. If you look close enough at the bottom, there's 10 milligrams in 10 mLs. So the way that I move forward with this now is I say, okay, 10 and 10 is the same as 1 and 1. If I have 10 and 10, then I have 1 and 1. So that means 1 milligram is the same as 1 ml. Now, if I want to give 0.8 milligrams, how many mLs do I give then?
0.8.
Yeah, 0.8. Simple enough. It's not, trust me, I'm not good at math. I'm not a math person at all, but this is fairly simple when you break it down. That one we'll do in person. I've got a different one than that. Let me pull up mine. They might be a little bit easier for you guys. Have you guys been shown the dopamine clock at all, or with drips?
We were gonna do drips last Thursday, but we had like 30 minutes left, and we convinced Liam to let us go home, and we'd do it this week.
All right. Well, I'm gonna give you a head start to it. How about that? All right. So let's look at this medication, which is lidocaine. Okay. bear with me through this. Lidocaine is supplied 2 grams in 500 mLs. So 2G in 500 mLs. I feel like I'm graffitiing. It's horrible. All right, 2 grams in 500 mLs. Your dose ordered is 2 milligrams per ml. What problem do I have right off the bat?
Need to convert grams to milligrams.
Okay, so the medication is supplied in grams, but my ordered dose is milligrams. So that's easy enough. Let's start with our 2 grams, which is what is at the top. If I want to convert that to milligrams, how do I do that?
Move 3 to the right.
Okay, so I add three spots to the right? So for this spot, I'm going to add 0. Damn it. 0, 0. There's my 3 spots. So that now gives me, instead of 2 grams, I now have 2,000 milligrams in 500 mLs. So what is 2,000 divided by 500?
4.
4. So my concentration per ml is 4 milligrams. Okay, does that make sense? Everybody with me there so far?
Yep.
Okay. I'm going to erase that. So if you need to take a picture or anything, do it now, because I've got to keep writing. So remember, we're at 4 milligrams per ml. So I'll write that back at the top, 4 milligrams per ml. Okay, so now that's what we call our concentration, okay? When we're talking about giving a medication that is in a bag like that, we can make a clock. And bear with me because this can get kind of confusing. But how we make a clock is we have to draw a circle, okay? Or a potato, apparently. Our concentration always goes at the top. So at the top of this clock, where 12 would usually be, we put 4. Down where 6 would usually, like 6 o'clock, where 6 o'clock would usually be, we put 2. Then we cut that in half. So 4, then the next number over here would be 1, because 1, 2. This number would be 3. We're moving in clockwise motion. And then we break it down per drip. So to do a drip, does anybody know which drip set we use? Are we going to use bigger drops or smaller droplets, you think?
Micro drip.
Micro drip. So a micro drip is 60 drops per minute. If you go grab a drip set out of your ambulance or whatever it is, a micro drip set is 60 drops a minute. We want to use a smaller drip set like that. When I mean smaller, I mean the needle is smaller because it's making more refined drops. So remember, 4 milligrams up here at the top of the clock equals 1 ml, right? So 60 drops, since that's the set we're using, also equals 1 ml. And then just cut it in half again. Cut it in half again. And then add 15 plus 30 gives me 45. So now you are ordered to administer 2 milligrams. So that's down here. So how many drops do you think I give?
30.
Yeah, it's 30 GTTS per minute. GTTS is how we abbreviate drops. Okay, who did I lose on that?
I think I got
You lost me.
And me.
Okay. Where okay, what point did I lose you at?
The 60, the 30, the 15, and the 45.
Okay, let's talk through it. So 4 milligrams equals 1 ml, right? It even says it on that bag. So for every 1 ml of fluid equals 4 milligrams of medication. If I grab a drip set, it's a 60 drop set. That means I have 60 drops per ml. It takes 60 drops to make 1 ml. Well, if I'm making 1 ml out of 60 drops, that also means 60 drops equals 4 milligrams because they both equal 1 ml. Well, I only want 2 milligrams instead of 4, so I just cut it in half. Instead of 30 drops, instead of 60 drops, I need 30. It would kind of make sense if you guys had a drip set in front of you to look at. That kind of, I mean,
That helped me a bit.
it's fairly simple, and we'll do another one. And you can, let's do dopamine down here. Don't pay attention to this math equation. Okay, dopamine. Actually, is there a dopamine one on here? Yes, there is. Okay. Using microdrip tubing, it says. So microdrip we know is what? How many drops?
60.
60.
60 drops a minute. Or 60 drops an ml, sorry. So remember that. Patient weighs 144 pounds. What do I need to convert that to?
Kilograms.
Okay, what is it?
Kilograms.
144 divided by 2.2. What is that?
65.
Okay. So that's my weight, 65 kilos. So I need to administer, if you look at the equation up there on 14, I need to administer 5. Let me move this down for you guys so it's easier for you to. Oh. So I can create some workspace. Okay, so they want me to give 5 micrograms per kilogram per minute, okay? You see that? So what is being ordered is 5 micrograms per kilogram, which I have 65 of, so I'm going to plug that in there, per minute. Are you with me so far?
Yep.
Okay. What's 5 times 65? Because I got to multiply those two.
325.
325.
Okay. So that gives me 325 micrograms per minute. Okay. Still with me?
Mm-hmm.
Okay. So our medication is supplied 400 milligrams, and I'm guessing that's a 250 ml bag. What's a problem again?
Micrograms to milligrams.
Okay, so I have 400 milligrams. How do I convert that to micrograms?
Three spaces to the right.
Okay, so 1, 2, 3, and I fill that in with zeros. 1, 2, 3. What's my new number then? 400,000, right? So I have 400,000 micrograms now. In 250 mLs. Okay, if I want to find my concentration, I have to do some division. All right. I have to do 400,000 divided by 250. What does that give me?
1,600.
Okay. And it actually says it right there on the bag. 1,600 micrograms per ml. Okay. So I've got what I need to give, which is right here. I need to give 325 micrograms, right? I'm supplied 1,600. So now I draw my clock. My God, we are not using that. Okay, so at the top of the clock goes your concentration. Okay, this right here. This goes at the top always. Whenever you figure out your concentration is. So we'll put 1,600 at the top. Okay. What's half of 1,600?
800.
800.
800.
Okay, so 800 goes below it. What's half of 800?
400.
400.
Okay, so that goes there. And then what's 800 plus 400?
1200.
Okay, so there's the outside of my clock. Okay. Now it said we were using a micro drip set. So how many drops equal 1 ml then?
60.
60.
Okay, so 60 drops goes at the top then. Half of that is 30. 30 is 15. 30 plus 15 is 45. And now we're plugging and playing. They want me to give 325 of them. This is kind of where we have to look at this and go, okay, 325 is probably, you know, not too shy off of 400 because 400's right here. 400's right here. So 325 would have to be like right here somewhere. So then we just say, okay, that's probably going to be around 13 drips a minute. And that's your answer. That makes sense. And you guys can practice this a lot, so I'm just trying to give you an intro right now.
So that one's a little bit, I mean, once you get down to it, after the math, kind of a guesstimation game.
Exactly. Yep. But I can get close. Now, there is another way that might be easier for you guys, okay, instead of the clock. So I'm going to erase this and show you the other way. But it only works in increments of 5 micrograms. So remember that, because you'll have to double everything then if you have a different dose. So let's just say I had what, 13 drops? Is that right? 13 drops a minute, I believe. Okay. How much did I say this patient weighs in pounds?
144, I think.
Yep, 44. Okay. What is 144 divided in half?
72.
72.
Trying to figure this out real quick because I did something wrong here already. This isn't the way I'm used to using, so give me 1 second. I hear a lot of scratching going on.
Sorry, that was me erasing.
You're fine. Okay, so let me see real quick. I had it saved because I was going to show you guys this. Ah, that's what it was. All right, so weight again was 144. Right, can you guys still see that?
Yes.
Okay. 144, knock off the last number. That gives me what, 14? Subtract 2, and this you always do this. Knock off the last number and subtract 2 equals 12. Drops a minute. Some people don't like the clock, so I found a different way to kind of show you guys that will get you almost the same results. I said 13 with the clock. This is saying 12, so we're right in the same ballpark. So you take the weight in pounds, you knock off the last number, and then subtract 2 off that. So I had 144. I knocked off that last 4, and then I subtracted 2 from 14. That gave me my 12 drops a minute. But again, that only works for 5 micrograms. So if I want to give 10 micrograms, this would essentially be double. Instead of 12, I'd be giving 24 drops a minute. If I want to give 15, it'd be triple. If I want to give 20, it'd be times 4. So let's do another weight here. If I have, a 220-pound patient. Okay. And again, we're not converting this to kilograms. We're leaving it in pounds. If I knock off this last number, that gives me 22. Subtract 2. Oh, my damn computer froze. 22 subtract 2, that'd give me my what? 20?
Yes.
This only works with dopamine, and it only works if you're starting out at 5 micrograms per kilogram per minute. But you can just double the dose. If you're up at 10, triple the dose if you're at 15 micrograms per kilogram per minute, and then multiply it by 4 if you're at 20. Again, only works with dopamine. So I hope you guys blow Liam's mind, because I will not be there Thursday night. It's actually her rehearsal dinner for my wedding. So I would probably get killed if I showed up at class. So this will blow his mind, because he'll show you guys the clock method and he'll show you long division and all that. But if you are able to tell him this, it'll kind of freak him out as to how you got it. And then
was he taught using Common Core math?
So how Liam, I know this sounds really weird, but how Liam was taught, because his parents are, not from this country. So he doesn't believe in the number 11 or 12 or 13. It's 1-1 or 1-2 or 1-3 or 10-1. Sorry, 10-1 is 11, 10-2 is 12, 10-3 is 13. So the way he does math is a little different.
Gotcha.
What's easier? Do you think the clock is easier for that, or do you think this is?
Most definitely this.
That's what I figured everybody would say. And like I said, I'm going to post this. Actually, you know what? He has his own worksheet you guys are going to do Thursday night, which is almost identical to this. So he's actually going to do one, I believe, with you guys for a little bit. And he's actually, one of our stations for skills is going to be nothing but med math and figuring it out. This isn't, don't complicate it any more than you need to. It's not horrible. It's just when we start looking at it and looking into it a little bit more, we get a little flustered. I know the day class today felt a lot better after the skills lab with med math because Liam spent a pretty good amount of time with them going through it, and actually they stayed after class and he answered in questions that they had for him. So what I'll do is, he gave you guys that basic worksheet, right? To convert like pounds to kilograms and milligrams to grams, and you guys have that?
Yes.
Okay. I will add this on D2L, but I'm going to remove some of these questions that he's going to go over tomorrow because I don't want to confuse you guys, or at least going to go over Thursday because I don't want to confuse you. Also, I will, if you have any questions, please email me or send me a message on Teams and we'll go through it together. I don't care if I have to meet with you one-on-one to go through and try to figure some of this stuff out. It's a lot easier in person when I can draw it on the drawing board instead of using the drawing tool on Microsoft Word. Are there any questions over any of this stuff? It's again, this is basic med math.
Let's reevaluate after Thursday and see if I still feel like I completed it.
No, and you know what? That's an option. If you guys want to, next Tuesday before we start the new lecture, we'll see after skills lab Thursday night. I know that we won't be up there for the Mesa City crew, but we'll see if it makes more sense. And then honestly, I can kind of quiz you guys a little bit the next Tuesday night on some of this stuff and see if you remember any of it. Does that work?
You're gonna post this for us?
Yep. I'm gonna edit
people. Okay.
I'm gonna edit it a little bit and I'll have it posted up tomorrow. Any questions on that? All right, okay, so I'm going to open this up. If you don't have any questions on it and you feel pretty comfortable with it, you can be done for the night. If you feel like you need more work on it, hang out in here and we'll go through a couple more. It's up to you guys. What do you guys think? Some of you, maybe?
I'll stick around.
Okay.
I'll do a couple with you.
Okay.
Yeah, I'll stick around. No guarantee it'll make any more sense than it does, but give it a shot.
All right, you can still see my screen, right? And don't worry about drips. The drips we're gonna have to do in person because it's a lot easier for when you guys can draw on a board. It's rough to try to teach online, and that's what I even told Cheryl today. I was like, I kind of feel bad trying to teach this online, but actually, you know what we can do is try to do this leave a fed at the bottom and then see how we feel about that. So let's do that. Let me get my drawing pad up here. Okay. Levofed is supplied (4 milligrams in 4 mLs. That's that vial right there. Okay. You are ordered to administer 8 micrograms per minute. So first we have a problem. We have milligrams and we need micrograms. So how do we convert this? If we have 4, what does it now become in micrograms?
4,000.
Okay. (4,000 micrograms in 4 mLs. Okay, you have to administer 8 using a 500 ml bag of fluid and a 60 drop set. So instead of 4 mLs, let's take this vial of medication, okay? So let's take this 4,000 micrograms, and we're going to inject it into the side of a 500 ml bag. So we now become 4,000 and 500. Still with me? If I take that whole vial, draw everything up, and inject it into a 500 ml bag of fluid, this is what I would get. Okay? Because the medication didn't change, I just put it into a bigger container. So now, with this, I know that there is 8 micrograms per minute ordered. So let's write that 8 mcg per minute ordered. Don't circle it. So now let's draw us a clock. What drip set did I say we're using? 60.
60.
So the 60 goes at the top because 60 drops equals 1 ml. Cut that in half, gets 30. Cut that in half, gets 15. And 30 plus 15 is 45. Now, there's something I haven't done yet. I have to figure out my concentration. So if there's 4,000 micrograms and 500 mLs, how many micrograms are in 1 ml?
8.
Okay. So 4,000 divided by 500 gives me 8. So 8 goes at the top, 4 goes at the bottom. Half of 4 is 2. 2 plus 4 is 6. And I want to give 8. So here's 8 micrograms. This is 2 micrograms. And this is 6 micrograms. If I want to give 8 micrograms, how many drops am I doing?
60.
Yeah, that's all it is. That would be the answer to that question, 60 drops per minute. And if I was using like a 15 drop set, then I would just put 15 at the top, and then 7.5 would go at the bottom, and then you'd have to 3 and a quarter would be next to it. Did that help out at all? That one was a little bit easier.
Yeah.
Yes.
The biggest thing that'll trip people up is when the question asks, it's like a multi-step question, where kind of like this one, where it tells you, okay, you have 4 milligrams and 4 mLs, you need to give 8 micrograms per minute, but you have to convert that milligrams to micrograms. If you don't, then you're literally stuck there trying to figure out, well, how the hell do I add a C to this mg? We'll do another one, except I'm gonna have somebody come up with weight, and I'm gonna have somebody come up with but we'll do dopamine. Okay, so somebody give me a dose between 2 and 20 micrograms.
12.
Okay, of course you got to pick a weird number. 12. Okay, so 12 micrograms per kilogram per minute. That's what's ordered. That's what you just told us that we have to figure out. But we need to figure out the person's weight because we see kilograms there. So how much does this person weigh?
250.
Okay, 250 pounds. Let's break that into kilograms. So divide by 2, divide in half, sorry, gets me 125. If I subtract 10% of 125, what do I get?
113.
Okay, 113. So there's our kilograms. So now we need to plug some numbers here. 12 micrograms times 113 kilograms is what? What's 12 times 113?
$13.56.
Okay, so that becomes 1356 micrograms per minute. So dopamine, I'll be honest with you guys, is always supplied. Your concentration will always be the same with dopamine. 1600 will always be at top because dopamine is always 1600 micrograms per ml. So cut 1600 in half, that gives me 800. 400 or 800 in half gives me 400. And then 400 times 800 is 1200. And remember, this is all micrograms. Imagine those are all dosages. We're using a 60 drop set. So 1600 mcg, we'll do this, is the same as 1 ml. 60 drops is the same as 1 ml. So I need to give 1356. Kind of an odd number, not going to lie. Wish it was a little bit different. Let's finish filling out our clock here. 30, 15, 45. Okay, now is where we're going to have to do a little guessing here. So if I need 1356. I've got 12 and I got 1600 on this clock. So I know it's somewhere in between there. So it's somewhere in between 45 and 60 drops. If I was to split 12 and 1600, what's the number that lies right in between them?
1400.
Okay, so let's add 1400 to this. So let's just split it in half. We'll add 1400 because it's a clock. So I'm close. And if I was to split 45 and 60 in half, what's half of that?
$52.5.
Okay. So 52.5 drops gives me 1400. If I want to be at 1356, I'm guessing, let's just put it right here. I'm guessing I'm going to be right around 51 drops. And that's just a guess, but it gets me close.
My math says 50.85, so 51 is pretty good.
Okay. So that's what we're going to go with, 51. Does that make a little more sense? How about this? Do you guys want me to make you a worksheet with nothing but these drips on them to help you work through them? And I'll put one on the front page as an example and how I got those numbers. And like, I'll actually put my math on it and scan it in and upload it so you guys can see that. I feel like that'd probably be more beneficial, to be honest.
Yeah, I think it's like that.
That'd be great.
Okay. All right, I'm gonna do that. I'll get that uploaded tomorrow for you guys. I'll be at the college in the morning anyway, so that works perfectly. I don't have anything new for you guys tonight. This is wrapping up pharmacology. Next week we jump into a whole new chapter. I believe airway management, if I'm not mistaken, advanced airway management. Skills session this next time is going to be you're going to learning adult and pediatric innovations as well as med math, and keep going over that for a while. So look forward to that. Any questions I can answer for you guys about anything? If you feel like you're going to walk away feeling dumb, just don't even think about it. It's fine. We'll get through it. I promise. I had a whole last class that didn't think they knew how to do med math, and they walked out, and over half of them are paramedics right now.
I feel like I'm not retaining a dang thing.
That's normal. 100% normal. And then halfway through the program, I'll pull you all guys aside, and you're like, I feel like I haven't learned anything. And then I'll remind you that you, 6 months in, I want you 6 months in to go explain to new you how to start an IV or how to do an intubation or how to do med math. And then that kind of shows you how much you really know that you didn't realize you did.
Is the midterm open book?
Yep.
Thank you, Jesus.
Yes, almost all my tests are open book. All right, guys, I got nothing further for you. If you don't have anything crazy to ask me, I will get this uploaded. Give me a little bit of time tomorrow to get it posted for you guys. But I will do my best to get that figured out for you. Anything for the good of our class?
Rudy, I appreciate you struggling and drawing that so I could see what was happening. That really did help out a lot.
And I really did struggle. I thank you. All right, guys. Been fun. Enjoy the rest of your night. I will get that upload for you guys tomorrow. And if you have any troubles with it, seriously, shoot me an email or use the chat on here. You can chat with me directly and it comes right to my phone.
Thank you, and have fun this weekend.
Oh, I will.
Thank you, Rudy.
Sorry for your loss, Rudy.